Good morning, everyone, and thank you for the introduction, Dr. McNeely. I was hoping that this was going to be in person, but alas, COVID has not really settled down yet. So I'll have to settle for at least a virtual meeting with all of you. In the next 45 minutes, I'd like to talk about a topic that has been influenced and a topic of interest that was influenced by my mentors there at UBC and has really guided what I've done in fellowship with the first fellowship at Toronto Western and my master's. So there we go. I am sending a virtual hello from SickKids where I'm doing my presentation today. And this is a view off University Avenue. Actually, this is the better view. So hello from SickKids. It's actually snowing outside right now. So as mentioned, in 45 minutes, what I'm hoping to achieve is, number one, provide a brief overview of the field of health services research. Then briefly just highlight two examples, and I tried to keep it as Canadian and local as possible of health services research. And finally, go into how we might be able to address some of the problems with transitioning patients from pediatric to adult care from a health services lens. So without further ado, what is health services research? So the CIHR defines it as a multidisciplinary field of scientific investigation that really studies how social factors, financing systems, organizational structures and processes, health technology, and personal behavior affect access to healthcare, quality of healthcare, cost of healthcare, and personal health and well-being itself. And if we were to take it further, we should ideally use the data or the results that we just obtained to either practice or change how we practice or influence how we make policy, whether this be on an institutional level or even a political realm, or it could be both. In the next few slides, I'm going to go over what exactly we mean by each of the outcomes like access, quality, cost, and health. So let's start with access. So what is access to healthcare? It can mean many different things to many people. One is it could be having insurance coverage, which really facilitates entry into the healthcare system. In Canada, with universal health, it's not really much of an issue when it comes to accessing hospital services, physician services, or procedures. But we should remember that there are some things that are not covered, like dental care, some allied health services, and some medications. Access may mean what services am I able to go to or use. So depending on where you are in the province, it might just be primary care. Or do you actually have the ability to go to a tertiary or quaternary center without much trouble to you? It might also mean access to diagnostic testing, MRI, CT scan, what investigation you need, whether this be for treatment or workup or for preventative health. Access may mean do you have the necessary workforce to take care of you? So that could mean nurses, allied healthcare professionals, physicians. So it's the whole gamut of a human resource. And ideally, these practitioners should also be culturally sensitive because health equity is also an issue when it comes to accessing health. Access may also mean patient education and awareness, or health literacy, to put it in the simplest term, because how aware these patients are affects how they interact with providers and how they use the healthcare system. Next, let's talk about quality. So quality can mean, similar to access, many different things. So it could be from clinical outcomes. So what is the complication rate? What is my success at removing some oncologic organ? Quality may mean safety or specifically a lack of errors and adverse events during a hospital admission. Quality may also mean timeliness. Am I able to get the investigations that I need or the treatment that I need in a timely manner before disease progresses? Quality may mean adherence by providers to evidence-based practice, because that's what we know so far provides the best outcome. Quality may also mean patient satisfaction, right? Is your treatment what the patient was hoping for, and did it positively influence them. When it comes to cost, I guess the biggest point here is that cost to whom? Cost can be cost to the patient from a financial standpoint, lost time from work because of their disease. It could be cost to the patient from an emotional or psychological standpoint with multiple admissions, multiple emergency department visits. It could be cost to the provider for the same, burnout, for example. Or it could be cost to the payer. So if you were in Ontario, it'd be OHIP. In BC, it would be MSP, or it could be private insurance. Lastly, what do we mean by health? Health could mean the absence of disease or cure. Health can simply mean survival. I did not die from my condition. Other things that might measure health: quality of life, personal sense of well-being, or functional status. So those are the things that we look at in health services research. And it doesn't have to be all of them for each study. Now, a few other characteristics of health services research. The research may come from varied disciplines. So you can have biostatisticians, people in the clinical sciences like us, those in the social or behavioral sciences, or in economics. It can be conducted in different settings. So you might do this in academia, in government, or in clinical practice. You might be doing it for many different reasons. So it could be to change your practice, or if you were a health leader or administrator, it might be to guide operational decision-making or policy itself. Health services research can focus on a broad group of people or population, or it could also focus on specific subgroups with a commonality. So for example, today we'll be looking at patients that require transitioning from pediatric to adult care. Lastly, it has significant overlap with different fields of health economics, health informatics, policy and technology assessment, just to name a few. So one type of research doesn't, it can fall into different categories. And when one does health services research, there's a few theoretical frameworks that we go by. This is probably the most popular one. And the reason why I'm showing this is we'll use this as for one of our examples later on. And this is the Donabedian healthcare model, also known as the structure, process, outcome model. And if we break it down to the left of the screen, you'll see structures of care. So some would refer to this as the nouns of healthcare. So what exactly, these are the factors that affect the context in which care is delivered. So this includes the physical facility, hospitals, the staff that we have, the equipment that we have. Process of care, which is the middle, is the sum of all actions that make up healthcare. So these are the verbs. Essentially, it's how am I using my equipment to diagnose patients? How often am I running my CT scanner, for example, to clear the backlog? When I'm seeing patients, am I doing preventative care? Or is it for education, or is it for treatment? Then health outcomes really contains all of the effects of healthcare on patients and population. So you might be looking at change in health status, change in behavior, or again, a clinical outcome for that matter. But really, the idea behind this model is that improvements in the structure should lead to improvements in the process, and in turn, should lead to an improvement in outcome. So that is just a brief and by no means extensive overview on what health services research is. So now let's look into examples of what's out there in urology. So the first example that I'm going to bring up is a randomized control trial that's based out of Princess Margaret Hospital in Toronto. And essentially what this group is looking at is in adult patients with clinical stage 1 testes cancer that's on active surveillance, they wanted to see if virtual follow-up through their web-based application called the Watchman was just as good as in-person follow-up. And what do I mean by just as good? What they're looking for is safety. That means loss to follow-up and compliance with surveillance schedule, incidence of relapse, delays in detection of relapse, and burden of relapse. And this screen grab or screenshot was from the abstract they presented 2 years ago, and the final paper is not out yet, but they are done accruing. And essentially here, what they had was 51 patients enrolled in virtual care and 51 patients enrolled to standard in-person care. And to go through some of their preliminary results, the big thing really was compliance with active surveillance was actually better in terms of adhering to the schedule in the virtual arm rather than the in-person arm. Now, part of it is going to be what is the effect of COVID on this, but when they did the preliminary or interim analysis, it was early 2020, and you'd think it wouldn't be much. The other thing was that in those with virtual care, 82% of them actually felt that the application was able to provide the same excellence of care as in-person appointments. So the patient's perception of that. There was no difference in relapse, incidence, detection, or burden from what they saw at that time. So when I look at this study, and putting it in context, we know compliance with active surveillance for testes cancer is difficult. And that's partly because of the number of investigations that has to be done, blood work, imaging, appointments. And in those studies that reported high compliance, like this one from the Netherlands, on the second line, the majority of patients actually live close to a university hospital or cancer center. So for me, when I'm looking at it from a health services research lens, this study and this application enables patients to obtain care despite factors such as the pandemic or traveling large distances. And it still enables them to access the center of excellence while saving some time and financial costs. So I would put this in the bucket of improving access to care and maintaining quality of care for this example. The second example I had was coming out of BC with Dr. Goldenberg's group, published last year. And this was a population-based administrative health data set study where they looked at in patients who were prescribed testosterone therapy, who was prescribing it, and were they adhering to guidelines? So for example, did they get testosterone levels before therapy, and did they get it after? From their study, they got over 37,000 men who were receiving treatment that they included for analysis. And again, selected highlights from this study. 85% of men had a serum testosterone measurement prior to initiation of therapy. And this was an increase over a decade span. However, only 36% of men on testosterone therapy had a serum testosterone measurement following initiation of treatment. Most prescriptions were also from general practitioners instead of urologists and endocrinologists. So when I look at this study from a health services lens, first, again, to provide some background on what the guidelines are, I had to look this up as well. Clinical diagnosis of testosterone deficiency is made when patients have testosterone levels that are lower than what is considered normal, combined with signs and symptoms. And in the event that patients have improvement in symptoms, but remain testosterone deficient, or they don't have symptomatic relief despite reaching target testosterone levels after treatment, then the therapy should be stopped. So that's what the guidelines say. So for me, this study actually identifies and shows us how guidelines are practiced in the real world setting. And you can see that, especially with the post-therapy initiation serum testosterone measurement, it actually isn't being followed, or adherence is quite poor. So this begs the question, if patients were on testosterone therapy and they may not be receiving benefit from the medication, should they be on it? So from a health services research lens, I would put this in the bucket of important for quality of care, cost to the patient, and patient health itself when you look at possible side effects for treatment. So again, two local flavors or Canadian flavors of health services research as an example. Now, if we were to move on to the crux of the presentation, how can we apply this with regards to transitioning patients from pediatric to adult care? So to begin with, transitioning patients is not as simple as making a referral to an adult urologist. And to me, this is the definition that quite simply encapsulates what we aim to do. And that is a purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented health systems. And part of the reason about that is how we deliver care is quite different in the pediatric and adult realm. And again, these are some generalizations. For example, when it comes to patient management, these patients with complex medical issues like spina bifida, for example, has an entire multidisciplinary team behind them, often led by a clear person running the bus or driving the bus, and that's a pediatrician. If referrals have to be made, it's within the team itself. It's quite easy to sort it out. You'll probably even get your appointment before you leave. In the adult healthcare system, each specialty works in its own silo. And normally that means that if you need to see someone else, then imagine the delays and not even the coordination of who makes the referral, who chases that down. And the other thing too is that if you need help from, again, a social worker, and I'll point it out later, it might not be as easy to get versus in a multidisciplinary setting. The care approach is also different. In pediatrics, we're used to having patients with their parents or caregiver that helps advocate for them, versus in the adult world, it would be patient-centered. So again, looking at the autonomy of that patient making the decision. Patient functioning is also different. So again, going into autonomy, in the pediatric setting, the caregiver makes the decision in a way. Clinic management is also different. When we see patients in the pediatric setting, our appointments take longer. We discuss issues that are just beyond what is the clinical problem at hand, really going into how is it affecting you, what ways can we go about it. In adult care, it's usually shorter appointment times because, again, the clinics are usually busier. Access to psychology and social work, great access in the pediatric care by and large, or at least easier versus much more difficult in adult care, especially if you don't have extended health insurance. Follow-up is also quite active in the pediatric sense, meaning if they miss an appointment, we have a coordinator hounding them down, versus in the adult realm, if they miss an appointment, it might be many years before they realize, oh, not the provider, the patient, oh, I should have seen someone. What we are trying to prevent really is patients feeling like they're falling off a cliff due to a lack of sufficient preparation, information, and support and skills. So in terms of the literature, what initially when transitional urology came about, what population was the focus? It was spina bifida, patients with spina bifida. But as you can see on the right of the screen, there's actually many conditions that ideally should have a urologist even when they graduate from pediatric care. And I've divided it according to what they might need. So patients with impairment in bladder function, so whether it be storage, emptying, or both, these could be patients with neurogenic bladder, so spina bifida or another cause. Exstrophy, posterior urethral valves, patients that may require upper tract surveillance, monitoring, and monitoring of renal function, with which we can ask our nephrology colleagues for help. So these would be, again, posterior urethral valves, neurogenic bladder, but now you're looking to patients with prune belly syndrome or nephrolithiasis. Patients with genital or sexual concerns. So these are patients with epispadias, selected hypospadias, especially the ones that had proximal hypospadias or multiple repairs, and those with DSD. So in terms of the current model of transitional care, the magic number really is 18. And the moment they turn 18, by and large, they have to use adult services. That's emergency department, surgeries, providers. So in the first 18 years of life, it's not what pediatric urologists do and should do is not just, again, what is the disease and how do we tackle it, but also prepare patients for that leap or jump. And one of the tools that we use, for example, is the transition readiness assessment, or assessment questionnaire to be exact, that have 5 domains. So empowering patients to learn how to talk to their providers, they themselves tracking their own health issues. Are they able to manage daily activities or care? If they do CICs, are they the ones doing it? Are they able to manage their own medications and keep track of their appointments? And some patients will never reach this because of neurodevelopmental issues. So in those regards, we get the caregiver to that level. And then when they turn 18, there's actually a lot of unknowns. And then when they go to the adult care, there's no clear definition yet of what defines a successful transition. Is it seeing an adult provider once? Is it seeing them 3 times? What challenges do these patients face? We think we know, but we don't really know what the nitty-gritty of it are. And if patients are on track but haven't really reached their milestones that we wanted to on that left side of the screen with my arrows, when do they actually make it? Now, this model is not perfect, and part of the reason is that during the transition time, the teenage years, it's a period where there's a lot of social, emotional, and neurodevelopmental changes to patients that some in the field of transitional urology would even argue about the need for an adolescent urologist, where this urologist takes over and takes care of teens to young adults until 25, for example, so that when they are transitioned, it is not during that teenage years or critical time. We've also identified some barriers to transitional care, and I've split it up into patient, provider, and health systems issues or difficulties. From a patient standpoint, it could be anxiety surrounding the unknown or the adult health system. They might have inadequate preparation from a transitional standpoint. Again, I mentioned transition coincides with major life changes, and parents may be conflicted, allowing how much independence do I allow my teenager to make his or her own decision making. And if we do it right with transition preparation and readiness, we should be able to ideally address these patient concerns while they are in the pediatric system. Now, there's also some provider concerns from the adult side. These adolescents with complex needs only form a very small part or portion of their practice. There's not that many of these patients. They may not have seen as many of these patients during residency or fellowship as well, and what the complications are. So again, that discomfort for what's not familiar. For patients that have been in the system or seen many providers, it might be difficult to establish trust with a patient as well, or a provider, because again, they've been through it. They've been through a lot. And last but not least, there's no incentive for adult providers aside from their goodwill, because these appointments will take longer than a PSA follow-up. And there's no incentive for that. From a health system standpoint, there's the practical side of things, like how do you transfer information from pediatric to the adult clinician? There are many runarounds to that. But the main crux really is funding. So in BC, where I would say funding is better organized than Ontario with the health authorities, the funding doesn't follow the patient. Right? And when you have various health authorities with different issues and priorities at hand, you may not have funding to establish new clinics, fund nursing support, or fund allied healthcare providers. When transition is poor, bad things happen to the patient. There's increased stress and anxiety, poor adherence to care, so medications that they may need, like those in medical therapy for stone disease, or those that need it for impaired bladder empty or compliance or detrusor overactivity, may not get refilled. They have poor clinical outcomes. So the issue with pediatric renal transplants when they go through transition is they start missing their medications, they forget to fill it, then they have a rise in creatinine and graft loss. Increased hospitalizations is an issue, and increased emergency department visits. So how does this all translate from a health services standpoint? So at Sunnybrook with Dr. Hirschhorn, who arguably takes in most of these patients from sick kids, they did, again, a population level analysis and review where they identified 1,200 patients with spinal dysraphism. And what they looked at was from 5 years before the age of 18 to 5 years after, how often were they going to the emergency department? And they found that the annual rate of ER visits progressively increased from 68 visits per person years to 105 visits at the age of 23. At the same time, though, the rate of hospital admissions decreased from 29 admissions per person years to 20 admissions per person years. And their abstract didn't really say why these patients were presenting to the emergency department, but I'm sure the data is there. But one might assume that it could be for something that doesn't require admissions, UTIs, pain, for example. They found that patients in the lowest income quintile, or those living far away from the tertiary care center, those with a diagnosis of neurogenic bladder or bowel, or patients that require mobility aids, have increased emergency department visits. So when you have data like this, the question then becomes, why is this happening and how can we fix it? Or at least that's what we should do in health services research. So if we were to apply that model that I showed earlier, the outcome being increased emergency department visits, yet reduce hospital admissions, and assuming that, let's say, it's from UTI or pain, then the question becomes, is there a structure issue or a process issue? So a structure issue might be, do they even have a primary care provider to assess them? Or do they have a specialist, like a urologist, if it's urology related, that can assess or optimize their current state of health? A process issue might be something like they do have a primary care provider, but they're unable to see them because the office hours are too short in a bad time of the day. There might be patient caps to how many patients the providers see, so they can't get access until 5 weeks later. Or it could be the physical part of the building. They don't have access to get there because of their mobility aids. It might be that these patients were grumbling all along and they needed some investigations, but they were unable to be carried out in a timely manner. Urodynamic, CT scan, ultrasound, for example. Maybe it's as simple as there's only one pharmacy in the small town because, again, it's patients that live far away and they can't get there because it closes early. Who knows? But again, this is the type of thinking that we would look into when we get data like this. This is a similar-ish study in the sense that I'll show you the outcomes are the same, but in a different setting. This was done in Michigan, where they looked at a 1-year snapshot of all patients with spina bifida and what health services were they using, number one. And number two, in patients who are over 18, because in their system as well, these patients had to be seen on the adult side, was there a difference between those that transitioned successfully and those that did not? So in this cohort, there's 40 patients that successfully transitioned, 61 did not. And you can see on the right side with the graphs, with blue being did not transition, across the board, doesn't matter if it's ambulatory care or emergency department visits, those that did not transition, you needed health services or access them at a much higher rate. Again, they didn't break down why they were in the emergency department. They didn't find distance from hospital or race or ethnic background or insurance coverage as a factor in their study. The only thing they found was male gender, less likely to successfully transition. So now you have two studies where, again, outcomes are similar, right? Patients who did not transition well need the emergency department or go to the emergency department much more frequently. But again, outcomes are only part of the story. And when you really dig deep into why and what can we do about it, we have to think about, how does geography or patient location affect this? Maybe there's a big preponderance of one ethnic or cultural group that views healthcare a certain way. Maybe they only want to seek care if it's really bad. Insurance coverage, again, they didn't show, but it might be. What's available? What else is available? Hospitals and physicians, right? Are there competing issues with the healthcare system, whether this be operational standpoint, like there's a pandemic happening, or from a political realm, like we want to focus on this. And again, there's going to be health care infrastructure and culture differences that would affect how you might tackle this. So if we were to go back on transitional care, there's been many models proposed on how it should be done. One is having an adult multidisciplinary clinic similar to the pediatric spina bifida model. And this is what they have in Halifax, for example, for spina bifida patients. Another is having monthly transitional care clinics where an adult urologist is present in the pediatric clinic. And this is from a paper I read in Belgium and one of the main centers. Another proposed model is that there is such a thing as an adolescent urologist, as I introduced earlier, that takes over care for these patients from adolescence to young adulthood. And the person who's probably most well known for that is a guy named Dan Wood in London, who is now in Denver, Colorado. Lastly, it might be having a pediatric urologist cross-appointed to an adult hospital to continue caring for patients alongside the adult urologist. And this is the model that they are trying to do and have set up here at SickKids. Now, if you were to ask me what would work for BC, the first thing is, from an outsider looking in, because it has been a few years since I've been there, this is how I see BC from a health systems or services standpoint. I see a place with vast geography, and healthcare is divided, responsibility for healthcare is divided geographically by these 5 health authorities plus the PHSA. I see one dedicated pediatric center, BC Children's, all the quaternary centers in Vancouver with multiple tertiary centers all around, Kelowna, Victoria, Royal Columbian Hospital, just as examples off the top of my head. From an infrastructure standpoint, I also see that all investigations, imaging, if done in a hospital, and selected documents are all connected by Care Connect. Again, this is important when you're handing over information. And from a from a human resource standpoint, I also see 90 or so urologists, and the majority of them, especially the recent hires, have a fellowship training of some sort, as it has been a requisite for employment. So this is what I look at, or what I see from a health system standpoint. Now, when it comes to improving transitional care in urology in BC, it's always easy to pick out how many issues there are. But if I were to focus on 2 things, it would be access to healthcare and quality of healthcare in terms of how fast or relative ease, to not oversimplify it, we might be able to introduce some measures. So the first thing is the forgotten gatekeepers, which are the primary care providers, especially when these patients are still in the pediatric realm. So the importance of primary care providers and family physicians in particular is something that pediatric societies acknowledge, including the American Academy of Family Physicians themselves, especially when it comes to transitional care, because unfortunately there's no equivalent in most places of that primary care pediatrician. The problem is that primary care providers have already identified a lack of knowledge or training regarding these childhood onset conditions. And this is compounded by the fact that most of the transition literature, not just in urology, but in different subspecialties as well, focus on specialist to specialist provider transition. Again, they are the ones that are forgotten. And it would be even worse if these complex patients under the age of 18 were seen by a pediatrician, and suddenly they see them at 18 plus a day with all these health issues. Where do you even start? So again, from one thing that I wonder and I want to do no matter where I end up practicing is encouraging patients to see their family providers on an annual basis starting at the age of 12 or 13. Again, sounds very simple. But the rationale behind that is that is probably their highest chance of getting a family doctor. Because if their parents have one, then hopefully they can just piggyback onto that. Versus imagine looking for one when you're already 18 or 19 when you need it. You have no relationship with anyone. If you were the provider, you'd be a bit wary as well taking these patients on. The advantage of doing that as well is that from a primary care provider standpoint, you still have the backup of the pediatric system. Again, not just the urologist, but psychology, social worker, for example. The second part of this is that from a pediatric urology standpoint, we should really simplify the goals of the care for these patients and what's expected from primary care providers, to not just set it clear for the providers, but for the patients as well, so that they know who to ask with regards to what issue. So I don't expect the primary care provider, for example, to address issues relating to sexuality in a patient with DST, or continence in a patient who's already had an augment and catheterizes through a metrophenol. But these patients may have issues with recurrent infections. And if you break it down, UTIs are something that bread and butter, they see every day. They know how to work up. They know what investigations to do. These are the things that the primary care provider may end up taking a bigger role in. Referrals as well, right? The referral has to come from somewhere, especially if an issue arises after you've already moved on to the adult healthcare system. Someone has to make them. And those are something, things that, again, primary care providers are good at. The second thing is establishing early contact with adult urologists. The rationale behind that is that if you establish contact early, especially when the patients are still in the pediatric environment, when they are still, again, familiar, comfortable, then in this setting, it established familiarity with the adult provider, and hopefully comfort. And this is something that's also been reported as an intervention, again, in one of the models I propose. It also allows all parties, pediatric, adult, and patient, to identify issues that may need continued treatment beyond the transition period. But practical constraints come into play. It's inconvenient for the adult provider. Imagine the lost income and in a fee-for-service model to schlep all the way to the pediatric hospital to see one or two patients, right? It might not be possible. So what if your patient's traveling from the interior and you can't expect the adult urologist to come with them? And last but not least, issues with hospital credentialing, like getting these providers into the pediatric hospital. So those are always things that in the BC health system were barriers. But if there was one thing that happened in COVID, it's the boom of virtual care. And it's really been brought to the forefront where how we deliver virtual care has changed. So in Ontario before, you'd only do it through the ministry platform called OTN. And that was the only way you can deliver it that you can get paid for. But now, telephone, Zoom, these technologies are utilized in almost, I would say, more than the OTN. When a urology study, again, by Dr. Hirschhorn's group, looked at patients' preference for urology visits, again, these are adults though, patients that live far away actually preferred the virtual visits. These were probably patients that wanted them to begin with, but again, with the pandemic, they're not able to do it. Providers also don't need to commute for an in-person meeting. So it eliminates some of that time aspect and travel aspect, and they can be reimbursed by the consult. So the second thing that I might try would be leveraging technology in facilitating either synchronous or asynchronous meetings with adult providers. And from an adult provider standpoint, it's also beneficial because now you have something that's a softer landing rather than inheriting them through multiple emergency department visits or admissions and complications. Now, ultimately, we also don't know how we are doing. So there are no publications to date that I'm aware of, and I could be wrong, on how urology patients in BC are doing after transitioning to adult care, again, from a urology standpoint. But we have a big part, or the important parts of the infrastructure already in place, like health databases, Population Data BC, which has some of the discharge abstracts, PharmaNet, MSP, and having this local flavor or data is very important for advocacy, because it's easy to read an issue that's happening in someone else's turf, but when it's happening in your own backyard, it also provides a bit more reality to those making the decisions. And as I mentioned, BC already has a lot of urologists that have specialty training of some sort in the community. And because there's not that many urologists in BC, again, only 90 or so, it's easier to form these connections or have these connections and relationships between providers, which is probably also another part in transitional care that is not emphasized enough. Now, what would be my wish list? It would be, of course, having money. Money is not a resource, but is a way to get the resources, like a nurse facilitator to follow up with patients who have transitioned already, social work support, even a specialized care program at VGH or somewhere for those patients with complex medical needs. Now, before I end, I have to put a disclaimer, right? When it comes to health services type research, really, it's hard for someone from the outside looking in, and any studies and intervention is really best addressed by the people, the stakeholders that are there, and the people that know the situation on the ground. I'm sure I'm making it sound simple, and it's not at all. I'm sure there's obstacles that are not yet realized that are lurking around the corner. And the other thing is, even the things like the political or social climate may affect programs or initiatives like this. It may enable them, or it could add a barrier to any of the plans. Before taking up any questions, my take-home points would be that, number one, transitioning from pediatric to adult care is something that is increasingly acknowledged as an issue in our field. And any solution isn't just going to be up to changes in the provider level or how we practice medicine. It would have to be a systems level as well to make it sustainable. And obtaining local data is key for advocacy efforts. So with that, I thank everyone who's stayed and to this point of the talk, and I'm accepting questions or comments.